Hi everyone and welcome to the PCOS webinar with Jo Gamble. My name's Sarah. I'll be here for the duration of the webinar. If you'd like to ask any questions, then please just click on the plus sign next to questions, type your question into the box and then click on send. Questions will only be answered at the end of the webinar, so we'll take a little time for questions. If you'd like to print out the PDF of the presentation, then you can just click on the plus sign next to handouts, and then you can click on the PDF and open it and print it out. And you can hide the control panel entirely by just clicking on the white arrow with the red background at the top of the screen, and then you just click on the arrow again to get that back to type in any questions. So I'll pass you now over to Jo. Thanks, Jo.
Thanks, Sarah, and good morning to everybody. This is the second of our female health webinar series. So today we're going to be talking about polycystic ovaries. And polycystic ovaries is something that I'm seeing a lot more of in my clinic. And I don't think it's linked to just a coincidence that I'm seeing more and more of this in my clinic. I'm seeing more of this in relatively young individuals, I'd say sort of young 20s to 25-year-olds. Why are we seeing more of this? Well, maybe it's linked to the multifactorial hormones involved in polycystic ovaries. We know that there's many different hormones involved in involved in the diagnosis of polycystic ovaries, but there's many more hormones that aren't even looked at by maybe a medical practitioner when making the diagnosis of polycystic ovaries. So today we're going to be looking at the patterns associated with polycystic ovarian syndrome or polycystic ovaries. We're going to be looking at nutritional intervention with the research behind it, and then I'm going to be bringing you a case study where I've applied many of the research that I'll be giving to you. So I used these two slides in my last webinar, and I've brought them back because we do have people who are just buying individual webinars, but I brought them back, even for those of you that saw them in the last webinar, because again, we're looking at the complexity of hormones. And actually, polycystic ovaries, I would say, is one of the most complex female hormone imbalances that I work with in my clinic. Why? Because there's so many systems influenced by it. Yes, of course, there's the endocrine system, but there's also, and it sort of affects every endocrine hormone from insulin to our sex hormones. But we've also got to be thinking about a much bigger picture here, the liver and production of sex hormone binding globulin. We've got to be thinking about the gut. We've got to be thinking about the nervous system. We've got to be thinking about inflammatory processes and how all of these are interwoven. And when we look at the research behind polycystic ovaries, we know that it affects multiple systems within the body. Talk about oxidative damage later on. Well, actually, oxidative damage is then a precursor for many other pathologies, isn't it? I'll talk about some of the pathologies specifically associated with polycystic ovaries, but then we need to think about it as a much more generalized picture. If you've got raised oxidative damage, you are much more likely to have other comorbidities, such as cancers, cardiovascular diseases, neurodegenerative diseases. Now, these might not hit now, but they may later on in life. So again, this is the second diagram that I've used before. It just goes to show how we need to work on a systems-based approach. So if we think about it as systems-based intervention, if you've got somebody who comes to you with polycystic ovaries and we only focus on the hormone, we're not necessarily ever going to get hormonal balance. And for those of you that work with clients with polycystic ovaries, I'm sure, like many of my clients, not saying all of them, but they've already turned up to me at a level of insulin resistant or type 2 diabetes. They've turned up to me maybe with a clinical obesity pattern. So at this point, we've got an imbalance in inflammatory processes. We've got a cardiovascular risk factor. So it's unusual, not saying it unheard of, it's unusual for somebody to turn up without some other form of system imbalance. And that's why we need to look at the whole of the bigger picture. Now, these slides, and these are relevant for all hormonal pathologies, but I thought I'd share them in this case, because in each of the 4 webinars, I'm bringing slightly different tools to you. So these are just really important case-taking history, information. So when you're doing your workup, that initial consultation, sorts of information that you need to be able to gather to support your client with polycystic ovaries. So we've got reproductive history. When did they start their periods? What's the history of pregnancies? That includes pregnancies that were terminated, miscarriages, menopausal onset and symptoms, perimenopausal problems. How long have they been in the perimenopausal phase? Things about their past medical history, any diagnoses, diabetes, immune system dysfunction, mental, emotional, bone fractures, sexual functioning. Do they have a libido? We're thinking about their diet, and as many of you are nutritional therapists, this is like your bread and butter. But things I'm very specifically interested in, of course, I'm interested in the whole of the bigger picture, but what's their caffeine intake like? How much sugar are they being exposed to? What's their essential fatty acids like? What's their protein amount and quality? How much of their diet is organic? What's the quality of the water? I'm thinking there about, additional toxicity, fluoride, etc., etc. Then thinking about their medication, and this isn't just what they're on now, this is what they've been on previously. Hormonal treatments, OCP. It's really interesting. I'm sure many of you have experienced this. I'll often ask a client what medication they're on, and they'll say none, or maybe over-the-counter painkillers or something. And then we go into talking about their sex hormones. I say, do you use any method of conception? Oh yeah, I'm on the pill. So it's interesting that many women don't see the pill as a medication, so to speak. So always ask that question, have you ever been on the OCP? Use of proton pump inhibitors. Now, we know that proton pump inhibitors are overprescribed, used for long periods of time. So we really want to be thinking about what could be the implications in the client of being on such treatment. Looking at cholesterol lowering meds. So have they been on a statin? Non-steroidal anti-inflammatories, and anything over the counter. Want to know if they've had any surgery. Want to know about their dental work, thinking about inflammation, their gum health, if they've got any mercury fillings, and whether they've had root canals. Then thinking about their fertility history, fibroid, endometriosis, and I'll be talking to you about this next week. Also thinking about sort of endocrine disrupting chemicals, so pesticides, plasticides, so exposure to xenoestrogen. We'll be talking about a few more specifics later on. Thinking about stress and where the major life stresses come from. Those of you that were with me last week, we talked about stress quite a lot. I mentioned the stress webinar that I've recorded, and it's still available as a recorded webinar. It is a condition I call a 21st century disease almost. We are conditioned from a very young age to be stressed. So we really have to look at what are those stresses. And we have to remember we each have a different ability to handle stress. So I've got clients who get really stressed with even the smallest, getting their children to school on time in the morning, or organisation. Actually, it's not our job to judge whether or not we deem that as a stressor ourselves. It's our job to support the client's resilience to stress. It's our job to give our clients tools to help with the management of stress. Thinking about trauma, things like sexual, physical abuse. And what's their support system like? Have they got a network of people that they can rely on? I always say to people, who is your support? Who do you talk to? And it's amazing how many people don't talk. Yeah, I'm fine. How often do we use those words? Yeah, I'm fine. Actually, what's fine? Let's define fine. Thinking about their bowel function, constipation, diarrhea, absorption, proton pump inhibitors, antacids, chewing. Do they practice mindful eating? And then asking that all-important question, when was the last time they felt well? So these 2 pages are just reminders of how important digging deep into a client's history to help us to piece together those pieces of that all-important jigsaw puzzle. So now let's go into thinking more specifically about polycystic ovaries. So it was also known as Stein-Lenfel syndrome, originally described back in 1935. Hyperandrogenism with chronic anovulation in women without specific underlying adrenal or pituitary gland disease. So this is one of the first definitions. It was characterized by multiple small cysts on the ovaries, and we often refer to those as pill-like cysts. So they're very different to a classic ovarian cyst that's usually singular and large, 5, 8 centimeters. These are small cysts. The small follicles on a transvaginal scan measure 5 to 7 millimeters. They never reach the pre-ovulatory size of 16 millimeters. And that's because they're immature follicles, because the hormonal signals aren't in the optimal balance. It's a disorder of a physiological response to an excess androgen. And we're going to go into all of this as we go through the webinar. Normally, the adrenal glands and ovaries secrete equal amounts of testosterone in females. But in polycystic ovary syndrome, the main source of androgens is from the ovaries, although there is some much later research which is quite interesting. Polycystic ovarian syndrome affects approximately 5 to 7% of premenopausal women. It is the most common endocrine disorder in women in reproductive age. So when I said I'm seeing more and more women, it's interesting that this is the most common endocrine disorder. Women with hyperandrogenism also have elevated lipoproteins, similar to men, which may increase the risk of cardiovascular disease. Now, we'll go into these in more detail. So there's 3 key areas that we focus on, very much in one of these vicious cycles, catch-22. Got a diagnosis of polycystic ovarian syndrome, which chicken or egg is associated with insulin resistance, which drove which. It's actually quite unclear in the research which was the original pathology. This drives an imbalance of sex hormones, the insulin resistance, which exacerbates the polycystic ovarian syndrome. And this is why it's such a multifaceted area to work with, rather than just a single area of intervention. And actually, when we look at the likes of endometriosis and fibroids next week, the imbalances associated with them are, of course, they're complicated. There's nothing about the human body that's not complicated, but a lot less multifaceted, which sometimes makes those conditions easier to work with. So some of the features of polycystic ovarian syndrome are the ovulatory and menstrual dysfunction, the hyperandrogenemia, polycystic ovaries, which have been seen on a scan, gonadotrophin abnormalities. This is now luteinizing hormone and follicular stimulating, insulin resistance and hyperinsulinemia, dyslipidemia, obesity, type 2 diabetes, and cardiovascular disease. Now, this doesn't mean every woman is going to have all of these. She might not be at a point where she has type 2 diabetes, cardiovascular disease, but these are the symptoms as a result of and driving factors in the presentation of polycystic ovaries. So a diagnosis of polycystic ovaries is made based on more recent 2004 Rotterdam Consensus, which agreed the following criteria for diagnosis. So we need to have 2 out of 3 of the following for a doctor to make the diagnosis: oligo and or an ovulation. So either periods that are irregular, spread out, or no ovulation. Clinical or biochemical signs of hyperandrogenism, and we'll go into those in a minute, and then polycystic ovaries on the ultrasound or direct inspection. Now, we can see people who have the cysts on their ovaries, but there's no syndrome associated with that. So these are deemed to be polycystic ovaries, and that's not always in people who go on. In fact, quite a lot of research over anorexics, so low weight anorexics having polycystic ovaries, because of the etiology behind the anorexia influencing the secretions of luteinizing hormone. Then there isn't the right levels of gonadotrophin releasing hormone to stimulate the maturation of an egg. So in those instances, again, you can see multiple cysts. but that isn't the same as the polycystic ovary syndrome. So I always just try and make that clear with my clients, you know, what was the diagnosis based on? And if it's a client that for another reason, or maybe somebody who like a high-end athlete doing marathon running, low body weight, maybe they could have a presentation of polycystic ovary for the same reason, but this isn't polycystic ovarian syndrome. Okay, so 75 to 85% of PCOS patients diagnosed with oligoamenorrhea or abnormal uterine bleeding. 40% of PCOS patients have normal menses, but they have chronic anovulation. So they're having a period, but they're not ovulating as part of that. And actually, one of the clients that I work with tests for luteinizing hormone because she isn't quite ready to have a baby, but it is something she would like to be doing certainly in the next 5 years. So she's been tracking for fertility, and she's getting no cervical mucus, she's getting no surge in luteinizing hormone, and she's not able to pick up a 21-day progesterone spike in her blood test. But she's having an almost like a 31 day cycle. So she's having a withdrawal bleed, but without ovulation. Only 20 to 50% of hyperandrogenic women with apparent normal or regular menstrual cycle have chronic, the word is missing, have chronic symptoms associated with polycystic ovaries. That's what I was supposed to be putting when I wrote that slide. Okay, so this here is looking at more like the differential diagnoses, things that we have to look at, ruling in, ruling out, that could present with some of the same symptoms of polycystic ovary, some of the same lab results, such as Cushing's syndrome. In Cushing's syndrome, which is an overproduction of adrenaline, we may see the excessive hair growth down the sides of the face, but that isn't polycystic ovarian syndrome. So these are differential diagnoses associate or things that you need to be able to rule out when you're looking or working with somebody who has polycystic ovaries. Okay, so when we think about the causes, well, the exact causes are unknown, but there are some genetic links. Of course, we're going to find some genetics. The more we look into genetics, the more we understand them. Thinking about defect in the hypothalamic pituitary adrenal axis. So this is why talking about with your clients stress response, looking at their stress hormones is so important. There's also growing evidence for the link between chronic stress situations and multiple hormonal imbalances, and this is why I focus on it so much with my clients. In polycystic ovarian syndrome, the women's eggs start to develop as normal, but for an unknown reason, none of the eggs become dominant or mature. The follicles remain on the surface of the ovary cyst and continue to secrete androgens, so that the androgen level in the bloodstreams are higher than normal. This is one of two reasons why we have raised androgens. This upsets hormonal balance required for a normal menstrual cycle, so therefore ovulation does not take place. Other contributing factors to androgen excess in women with PCOS compared to those that have no diagnosis include an elevated serum level of androstenedione, which is converted to within adipose tissue to testosterone. Now, this is the non-methylated pre-hormone, so it has got that ability to make those conversions because it's a pre-hormone, and therefore give us a greater percentage of unbound active testosterone. And this is one of the things that we're looking at when we're testing, is this level of free testosterone. In the early phase, the menstrual cycle, circulating estradiol levels in women with PCOS are equal to those without. However, mid-cycle elevations of estrogen and progesterone that normally occur after ovulation are absent because of the cyclical progesterone secretion. The action of estradiol on both the hypothalamic pituitary axis and the endometrium is unopposed. So both progesterone deficiency and acyclic estrogen production, so we don't have that nice cycle that I showed you in the last webinar, And this then has an effect on the endometrium, which may cause it to become hyperplastic, which may cause intermittent and heavy uterine bleedings and increase the long-term risk of endometrial cancer. So this is one of the pathologies, not others, but one of the pathologies that we do know that PCOS clients are at higher risk of. These effects may be compounded, especially in patients who are obese, by increased levels of estrogen produced from the fat cells. And I'm going to show you a diagram in a little while where we look at the circulating hormones. Okay, so these are some of the clinical signs. So amenorrhea or oligomenorrhea, so absence of periods or wide, long cycles. Hirsutism, excessive and increased hair growth in women in locations where the occurrence of hair normally is minimal. So sort of male pattern hair growth around the chin, upper lip, chest, navel, back, tops of arms. Now, I've got clients who do amazing jobs of removing those hair. There's loads of great techniques on the market, not my area of expertise. So don't just base it on clinical, like your eye, because some of the women that have got polycystic ovaries that I see don't look like they have any abnormal hair growth. So I have to ask them, I go, yeah, I spent hours having the follicles removed by some form of hair removal procedure. Acne on the face, back, and the chest. Insulin resistant and raised abnormal adiposity. So we're thinking there particularly about sort of central adiposity. Very common to see like an apple-shaped presentation. Infertility. Now the client might not at this point be trying for a baby, but a lot of women, in fact, I had a client who just said, you will, the doctor said undiagnosed, you will have to have IVF treatment to come back when you're ready. But then the reality is many of my polycystic ovaries clients that want to have a baby that are clinically obese are not allowed to have IVF on the NHS. So it's a double-edged sword, really. And then we've got this acanthosis nigrans on the neck. Well, it isn't just on the neck. These are brown to black, velvety hyperpigmentation of the skin. So it just looks like brown excess pigmentation. So you might see it on the neck, you might see it under the armpit, you might see it, client might report it in the groin and around the umbilical area. This is associated with excess insulin levels. Okay, so let's go into hyperandrogenemia in a little bit more detail. It refers to above normal levels of circulating endogenous androgens, such as total, unbound, or free testosterone. So this is something that's not bound to a binding, such as sex hormone binding globulin or albumin. Androsterone, which I said was the non-methylated prohormone. DHEA sulfate, and I'm going to talk to you about that in a little bit more detail. So testosterone circulates bound to sex hormone binding globulin and albumin, and only the free fraction of the testosterone, so that's the unbound, enters into the target tissue. So assessment of free testosterone levels must be much more sensitive for diagnosis of hyperandrogenemia than total testosterone, because the total testosterone is that that's bound and that that's free. So sex hormone binding globulin, like I said, is one of the binding, it's the main binding tool for testosterone. It also binds to DHT, the more proliferative form of testosterone, and also to estrone and estradiol. Sex hormone binding globulin plays a key role in regulating the bioavailability of sex steroid concentration. So how much of it is free, how much of it is available. Sex hormone binding globulin is produced within the liver. So we now have to start to think about the implications of liver toxicity, liver clearance, phase 1, phase 2, SNPs that could influence the workings of liver detoxification. 20 to 30% of PCOS patients have elevated DHEA sulfate levels, but also increase in other hyperandrogenic disorders. DHEAS levels also decrease with age. So it's not like it's saying it's not the most sensitive of measuring tool. It's part of the bigger picture. And actually, most of my clients with PCOS don't present the same as a textbook would present. And this drives clinical manifestation of the hirsutism, acne, and androgenic alopecia, which I'm going to go into now. So acne and androgenic alopecia doesn't affect all clients with polycystic ovaries. 15 to 25% may present with an acne. Acne may actually be part of why they were diagnosed. So they've been to the doctors, they've had antibiotics, they've had Roaccutane. They've not shown any clinical remission on medical treatment. They may push because of other symptoms such as long menstrual cycle, and that might be why their ovaries were ultrasounded, hence the diagnosis. So sometimes this is the driving force behind the diagnosis. Androgenic alopecia or scalp hair loss. A client said to me only on Friday, Joe, my landing zone is going thin. Okay, it's quite a funny analogy she was using. She means the area down the middle, which is where male pattern baldness. So we're thinning. It doesn't mean they've got complete hair loss, although it can happen, but usually you're thinning, and actually that's much easier to see in clinic because you can almost see through the hair on the top of the head. Affects 5 to 50% of PCOS patients. So some other skin complications. So we've talked about the acne, and this can also present as like a cystic-based acne. So these are the skin conditions that we start to think about when we're looking at the bigger picture. So 9 main areas that we might see hirsutism in one of our clients. So on the upper lip, the chin, the chest, the upper back, the lower back, upper and lower abdomen, upper arms and thighs. Now for some women, this is the most difficult part of the diagnosis because it has such an effect on their confidence. I've had clients that said that they don't dare go into relationships because of their excess hair growth. So, you know, it can be a big factor for them. Prevalence of hirsutism varies according to race and ethnicity, and actually in Asian population, this is usually higher. But is that because in some Asian populations, generally we do see more hair and the hair is darker? So I've started to mention about these gonadotrophic abnormalities. So we might see accelerated luteinizing hormone pulse amplitude, which leads to increased secretion of luteinizing hormone. And this is encouraging the secretion of these multiple cysts. But follicle stimulating hormones are normal or decreased. So the ratio, which is so important when you're looking at luteinizing hormone and follicular stimulating hormone, it's really important when you're looking at it with regards to infertility, which I'm going to be talking to you about in 2 weeks' time. More than 75% of PCOS patients have a dysregulated gonadotropin function. So if nothing else from a testing point of view, having their FSH and their LH tested by their GP, which most GPs will test for this, is all important. Ineffective suppression of the luteinizing hormone pulse frequently by estradiol and progesterone. So we lose that normal rhythmic motion throughout the cycle. Androgen excess increases luteinizing hormones by blocking the hypothalamic inhibitory feedback of progesterone. This works on a negative feedback cycle. The androgens block the negative feedback, hence why we don't get the drop in the surge of luteinizing hormone, which we would see in a normal cycle. I refer to normal, I'm referring to a textbook case. 50 to 70% of women with PCOS also have insulin resistance. Now, we know that insulin resistance, again, is a continuum, isn't it? Between, like, the far extreme is diabetes to, yes, we are showing some signs of insulin resistance, but we're not at the metabolic syndrome or the diabetes yet. But it is a roller coaster. defined as subnormal target tissue response to a given amount of insulin. So the tissue isn't hearing the insulin. It results in hyperinsulinemia by the islet cells. So therefore, to maintain normal glucose levels, the pancreas is having to work harder. Well, remember, the pancreas is not a limitless tank. And this is why somebody who has got very poorly managed type 2 diabetes or long-standing type 2 diabetes ends up insulin dependent. And then we've got all of the other comorbidities associated with diabetes, peripheral neuropathies, damage to the vessels behind the eyes. Haven't really gone into that today, but we have to think about that bigger picture, other conditions associated with this insulin resistance. This can lead to elevated circulating levels of glucose. So we might see that on a HbA1c or a fasting glucose, impaired glucose tolerance. So you might have your client do the glucose tolerance test where they go in fasted, have a blood test, drink a sugar solution, it's usually Lucozade, wait 2 hours, and then have a second blood test. That one's less commonly done in somebody with insulin resistance, more commonly done in somebody with women who are pregnant and they're looking to ascertain gestational diabetes. It's often done in type 1 diabetics as well. It's one of the less common blood tests. It's quite difficult for your client to have to spend over 2 hours sat in a hospital waiting area. Insulin resistance may not always be accompanied by elevated circulating levels of insulin. So even if the person sat in front of you is of optimal BMI, please do consider having their HbA1c and their fasting glucose tested also. So some of the things that we might see in somebody who's got insulin resistance, weight gain, especially around the trunk, so increased visceral adipose tissue. You can usually see this to the naked eye, although be aware of baggy tops to hide it. And ideally, you should be doing waist to hip ratios of your clients, or certainly of a client like this. I don't do waist to hip ratios of all of my clients, but if I'm suspecting something like insulin resistance, then I really am going to want to know what their measurements are. Dysglycemia, difficulty losing weight, and this might be somebody who's been on a low calorie diet, still not shifting any weight. Family history of diabetes or menstrual irregularity, obesity, higher waist to hip ratio. And really, this is just a thought process for you to take you through that. So over nutrition, think about what it is that you're seeing to me, how much portion size, how many eating episodes. Somebody who's got metabolic syndrome, I want them eating ideally 2, maximum 3 eating episodes a day, not small grazes, because they're constantly producing more and more insulin. So think about portion control, think about number of meals and snacks that they're eating in a day, high insulin levels, increased lipogenesis. We're going to look at that when we look at the cardiovascular. Lipotoxicity. Remember, we hold on to a lot of our toxins in our fat cells. Hyperglycemia, metabolic inflexibility. So the scenario does continue to increase. And really, this is a research paper that just backs up exactly what we need to be thinking about when we're looking at metabolic syndrome. Also thinking about increased blood pressure, raised triglyceride levels, lower HDL cholesterol. So they might not present with a cardiovascular disease now, but is it something that is ticking away behind them? A bit of a ticking time bomb. So this is a great pictorial that really looks at the pathways linking hyperinsulinemia and hyperandrogenemia and other related disorders. So insulin directly acts on the ovaries alone and along with luteinizing hormone can enhance ovarian androgen production. It indirectly also increases androgen levels by reducing hepatic production of sex hormone binding globulin. So as I mentioned, we've got to think about the liver and insulin-like growth factor binding protein. This then elevates free testosterone and free insulin-like growth factor. Excess androgen then impairs follicular genesis, resulting in the menstrual disorders that we've already discussed. The development of the multiple cysts in the ovaries. Insulin resistance increases the risk of development of metabolic disorders, diabetes, hypertension, dyslipidemia, and cardiovascular events. So that's what we're looking at here. It's a pictorial that brings together what we've been talking about. Not necessarily saying you need to go through that with every client that you see, but it's just an interesting pictorial to bring it together. Research paper here, marked impairment in insulin's intracellular signaling cascade are present in fat cells from type 2 diabetic patients, including reduced gene and protein expression. So the longer term implications of this insulin resistance have far greater researching. These are some of the things that we're looking at now. So hormone and metabolic imbalances in PCOS then predispose you to metabolic syndrome, insulin resistance, abdominal obesity, hypertension, blood lipid profile abnormalities, high CRP, so we can see that inflammation is joining us, high homocysteine levels, cardiovascular disease, type 2 diabetes, endometrial cancer, which I went into, depression and anxiety. Is that cause or effect? Quite often these people cannot lose weight, and that then causes more and more and more depression, can't get pregnant. So what are some of the investigations that need to be undertaken? So serum testosterone and other androgens may be raised, maybe looking at DHEA levels. Luteinizing hormone hypersecretion may be shown. Estradiol should be normal, but estrone levels will be elevated. Ovarian ultrasound may show the pill necklace of the cysts. Serum prolactin levels may be raised. Blood glucose may be raised. Cholesterol levels, especially if a protein little a, may be raised. Sex hormone binding globulin may be decreased. So not all of these are labs that a GP or endocrinologist will do. You'll be able to get the luteinizing hormone, you can get sex hormone binding globulin, you can get prolactin, you can get blood glucose levels, you can get cholesterol, FSH, LH, and triglycerides. And then we've got to be thinking about what additional labs might you want to do. Not for you to make the diagnosis, because A, we don't make diagnosis, and B, it's not about, diagnosis is a word, isn't it, or a series of words. It's about the pathologies associated with the diagnosis in your specific client. That's what we're looking at. So we've covered most of these biochemical features. I also just want to mention sleep apnea. There is high prevalence of sleep disorders in women with polycystic ovaries, even in those that are not overweight and obese. The pathophysiological mechanism isn't clear, but androgen excess and insulin resistance have been postulated to contribute to the constellation of disordered sleep. How many of you have ever sent a client off for a sleep study? I actually have done it quite frequently, because if your client is not sleeping or breathing properly in their sleep, it will drive many of these symptoms. I would say to my clients, if they have a partner that they sleep with, ask the partner, do they ever hear them waking up, gasping for breath? The client themselves might not be aware of it, but sending for a client for a sleep study is not a difficult thing. They do it at home. They have to have a referral, and they come home with a machine on that monitors their oxygenation through the course of the night. We also saw in here that, as well as talking about the insulin resistance, which we've covered, thinking about elevated leptin, and then of course leptin resistance. So we know leptin is an adipokine. It's produced in the white adipose cells in proportion to our fat content. Therefore, if we've got increased fat levels, we've got increased leptin. Increased leptin suppresses appetite and decreases fat storage. So leptin is a really good thing, agree. However, we now understand that people with obesity are often leptin resistant. In fact, obesity promotes a number of cellular processes that weaken leptin signaling. So this then doesn't turn off their appetite, and therefore they just feel hungry all of the time. So what are some of the things that we might want to consider from a more naturopathic testing point of view? Well, you can ask to have your clients' insulin levels tested, looking at their total cholesterol, their triglycerides, their HDL, their LDL. Might also be thinking about a salivary adrenal stress index, and I use that in one of the case studies that I bring to you. Salivary or serum expanded female panel, including testosterone, free testosterone and bound testosterone, luteinizing hormone to follicular stimulating hormone ratio, glucose tolerance test, a thyroid panel, looking at a blood lipid profile. Now we know that when you go to the doctors, you're only going to get HDL, LDL, triglycerides. That's if you're lucky. So what we want to look at is the bigger profile, things like high serum CRP, so inflammatory processes linked to the cardiovascular system, homocysteine levels, thinking about the breakdowns of the LDL, the LDL particle size, LDL particle number. These are all part of that bigger picture. A research study here that looks at best methods for identifying and treating PCOS. It does report in the whole of the bigger picture that actually it isn't such an easy condition to diagnose because it's so multifaceted, and it does very much have to go on a clinical picture. But we do need to look at levels associated with androgens and insulin to be able to support the bigger picture. Then we think about circulating inflammatory markers. So this research study talks about women with PCOS exhibiting an elevation in circulating CRP that is independent of obesity. This finding corroborates existing molecular evidence of the chronic low-grade inflammation that might underpin the pathogenesis of this disorder. Now, we know that actually inflammation is a good thing, don't we? It's our first line of defense against injury or invasion. But it's when it's a chronic situation that we need to be more concerned about. And in polycystic ovaries, it is chronic. So me burning myself and getting a red rim around the area is a really good way to look at it for my body to heal itself. But actually, that's not what I'm dealing with here. I'm dealing with long-standing, maybe low-grade, but nonetheless long-standing inflammatory processes. Might also want to be looking at DHEA and DHEA sulfate levels. We know that DHEA is the principal human, it's actually the C19 steroid hormone. DHEA has very low androgenic potential, but serves as a major direct or indirect precursor for most sex steroid hormones. And when we talked about either pregnenolone or the cortisol steal last week, you could see in the diagram how the precursors, cholesterol, pregnenolone, get driven away from DHEA in a state of an emergency. Because I always say to my clients, who reproduces in an emergency? DHEA is secreted by the adrenal glands, and production is at least partly controlled by cortisol hormones. But the bulk of DHEA is secreted as DHEA-S. Both hormones are albumin bound, but binding of DHEA-S is much tighter. In gonads and several other tissue, most notably the skin, our steroid sulfate can convert DHEA-S back to DHEA, which can then be metabolized to the stronger androgens and to estrogens. So testing DHEA salivary and DHEA-S, I do that through serum, I do it through the doctor's laboratory, are a really important factor in looking at both of these. So medically, what do medically the doctors have to offer? So they might talk about diet to reduce insulin resistance and central adiposity. The first medication that's given out, and this is often given out even to non-obese individuals, is metformin to reduce insulin resistance and increase ovulation. The OCP, for those not wanting to conceive, to give a withdrawal bleed, not a menstrual cycle. And then we've got some anti-androgen medications. And then we've got clomiphene citrate, which may be used for ovulation induction. So this is part of the fertility workup given to polycystic ovary clients. So to give it them to help stimulate, hyperstimulate the ovaries to produce an egg. So what are some of the therapeutic aims that as a practitioner we might want to consider? Well, certainly decreasing central adiposity. That's really quite important, isn't it? Decreasing insulin resistance. Promote estrone clearance by supporting phase 2 pathways. Lower luteinizing hormone levels and circulating androgens. So there's some of the things that I'm thinking about when I'm working with a client with polycystic ovaries. So what sort of intervention helps with essential obesity? Exercise at least 1 hour for 3 times a week. I mean, that's the minimum. In order to activate the GLUT4 transporters, we ideally should be doing, even if it's 15 minutes a day, I ideally like to get my clients exercising on a daily basis. This is a minimum. Now, what you've got to remember is, if we've got somebody with morbidly obese that hasn't exercised at all, this is a really good starting point. Increase fiber in the diet. We also talked about lipotoxicity. So we need to be able to bind toxins and support elimination. Reduce trans and saturated fat. Decrease sugar and refined food intake. And increase not just the quantity, but the quality of the protein that the individual is eating. And again, this is a diagram that I have used with clients where I've shown them what the implications of their obesity, and we're going to go into looking at the more cardiovascular in a minute, but we can see that obesity drives many further imbalances within the body. And actually a client does need to understand this. Now, traditional therapy would require that each of the metabolic risk factors be singled out and treated separately, resulting in multiple prescriptions. And you may have worked with individuals before that have had this presentation of they've got their metformin, they've got their anti-androgens, they've got their cholesterol lowering drug, they've got their blood pressure medication, but actually it's not getting to the root cause. They may even be on multiple blood sugar management medication, but still they're carrying a raised HbA1c. Looking at the glycemic load diet, or even thinking about a modified Atkins diet may be needed. Now, I am not a big up on, just stick them all on keto. Keto's become very fashionable, hasn't it? However, a short, sharp burst of a modified Atkins or ketogenic diet has been shown to lower blood glucose levels. So it may be that we need to work with the individual, but please do remember, if you're working under the remit of something like a ketogenic based diet, I don't like to leave people on it long term. And actually ketogenic has come about from a diet to control epilepsy, or should I say refractory epilepsy. This is the most serious type of epilepsy, uncontrolled by medication. Now, in an individual that is treated, and I can say treated because it comes from their medical practitioner with a ketogenic diet, they are monitored 6 monthly for their cholesterol levels, and annually their kidneys are scanned for kidney stones. And if either of those, cholesterol goes up or kidney stones, are found, then in those instances, the diet has to be stopped. So that's the seriousness that needs to be respected when recommending a ketogenic diet. However, it is shown in research to decrease insulin resistance. So I'm not against it. I'm just sort of wanting you to have the respect for it, but that kind of diet does require. And certainly if you don't want to go that far, thinking about reducing carbohydrate intake, like really reducing it and looking at the quality of the carbohydrate with good quality lean proteins and essential fatty acids. We also want to be promoting estrogen clearance. I'm spending more time focusing on estrogen clearance next week when we're looking at endometriosis and fibroids, because they're both conditions associated with more estrogen dominance. But in order to do this, let's just skin it over it today. We're thinking about evaluating bowel function and microflora of the intestine, and that's so important for the beta-glucuronidase pathway, which I talked about last week and I'm talking about again next week. Increase the brassica family. Support phase 2 liver clearance through nutritional herbal support. Even just incorporating culinary herbs is so important. Now, these are just, I don't need to read these to you. These are just some of the things that we associate with androgen excess. And also thinking about what potentially can promote and inhibit aromatase. So some of these are pharmaceutical medication, but also we're thinking about nutraceuticals. We talked a lot about promoting, or more so inhibiting, I should say, cortisol last week when we were thinking about PMS symptoms. So you've got to be thinking about how to support your client's management of these hormonal imbalances. In PCOS, the ovaries produce up to 60% of androgen, whilst the adrenals contribute to the remaining 40%. But it is established that androgen incoming from both the ovaries and the adrenals are the underlying source of the hyperandrogenemia in polycystic ovarian syndrome women. When ovarian androgen synthesis is suppressed with gonadotropin-releasing hormone agonists, so like medication, PCOS women were found to have higher androgen levels in comparison to normal women, thus suggesting adrenal overproduction of androgens. So this is where we're starting to understand, okay, there's way more to it than just the ovaries and the adrenal glands. And this is where we're thinking about sort of genetic links between the two. Polycystic ovarian syndrome complex disorder in which a small number of key genes interact with environmental factors, the balance of which determines the disease outcome or the comorbidities associated with the disease. The condition is known to run in families, and several genes have been identified that are thought to influence PCOS susceptibility. These include genes involved in insulin signaling as well as androgen production and activity. This research study here is looking at the link between these genes, particularly in Asian women. They were looking at the insulin-like factor 3, which is secreted by the Sequel cells in the ovaries, which are involved in androgen production. Now, this research was more specific to Asian women, but here we can see multiple polymorphisms and the potential result of those polymorphisms. Now, I guess it's just like anything from an epigenetic point of view. You may have these polymorphisms, but it's the environment that you bathe them in. Remember, it's the environment that pulls the trigger. So if you are born with a susceptibility to blood glucose imbalance, insulin resistance, and you are weaned from an early age on a high sugar diet, the likelihood of developing polycystic ovaries earlier on is much higher than somebody whose diet is introduced and maintained as what we would refer to as a good blood glucose management diet. I've talked a little bit about stress already, but some authors argue that stress may be an important precipitating factor in PCOS. Well, I just talked to you about, we suppress the ovaries and actually the adrenals become much more activated in the process. Underlying stress production, cortisol releasing hormone increases, stimulating the release of cortisol and further androgen. So the higher the stress, the higher the androgen production. And what factors perpetuate adrenal driving. Well, these are just some of them. You add to the list. You talk to your clients about their stressful event. Central adiposity increases the conversion of androgens to estrogen. The resulting estrogen dominance can then disrupt further levels of gonadotropin-releasing hormone. The elevated luteinizing hormone, low follicle stimulating hormone, further stimulates androgen production, eventually leading to menstrual irregularity and infertility. And this is a big part of why many PCOS clients might present at your door. They might have had PCOS for many, many, many years. They might be treated with metformin or other medication, but now they want to start trying for a baby. Toxicity. What's the implicating factor in toxicity? Is this why we're seeing more polycystic ovaries? BPA levels were significantly higher in the total PCOS group compared with their controls. PCOS women lean and overweight have higher BPA levels compared to the corresponding group of lean and overweight individuals. A significant association of testosterone and androstenedione with BPA was observed. Okay, so here we're thinking about, is toxicity a driver behind polycystic ovaries? I don't think it's the cause, but is it a driver? And what about inflammation? We know that those fat cells, that visceral adipose tissue, produces its own inflammatory cytokines. What's more, by stimulating androgen synthesis, these inflammatory mediators also seem to contribute to the maintenance of the syndrome. Another vicious cycle. So what does this tell us about needing to support a client from an anti-inflammatory point of view? We know that inflammation influences multiple systems within the body. And this is a great diagram. So as like a reference tool for you to look at, what would you most likely see in the blood? Raised interleukins, raised TNF-alpha, raised CRP, raised lipoprotein B, raised insulin, raised glucose, raised triglycerides. But then we've got this low adiponectin. Why would adiponectin be low? Because we know it's secreted from adipose tissue. However, plasma levels of adiponectin are especially low in individuals with visceral obesity. It's believed that adiponectin deficiency may play an important role for many of the negative metabolic consequences of visceral fat accumulation. Several clinical studies have shown that low production of adiponectin correlates with the development of insulin resistance and type 2 diabetes. It is also a driving factor behind further cardiovascular diseases. Other studies have shown that low levels of adiponectin are associated with raised levels of several different markers of inflammation. So it's quite interesting, the multiple areas that now are starting to be impacted. So what hormone disruptors might we be thinking about exposure to? So think about, where have they worked? What do they put on their skin? What makeup do they use? What's in their mouth? What sort of fish intake have they become exposed to? So this is just a reference tool for you to look at. Oxidative stress. I mentioned oxidative damage earlier on. We know that inflammation drives oxidative damage. We know that oxidative damage is a driving factor behind many different forms of cancers. So whilst endometrial cancer is sort of the specific to known to polycystic ovaries, actually generally is there an increased risk of oxidative damage because of the raised oxidative damage. Weight loss. So studies show that loss of intra-abdominal fat is associated with resumption of ovulation in women with PCOS. So it's not all bad news. We have got the ability to reverse some of the symptoms, but weight loss has to be an integral part of that protocol. It also improves insulin sensitivity and lowers cardiovascular risk. So like I said, with these individuals, you really do need to be looking at a low GI diet and going down the line of intermittent fasting, maximum of 3, ideally 2 meals a day, with a window from one to the other, so evening meal to breakfast, of 14 to 16 hours. That is optimal. And if we aren't quite radical in our approach to dietary intervention, then we might not see any results. I had a client come to me having spent hundreds and hundreds and hundreds of pounds on personal training. And while she said, I feel fitter, she hasn't lost a single pound. She hasn't lost a single centimetre either. So it's clearly not working. Now, that PT has had her on an 800 calorie a day diet. It's not working, is it? But it's all about the quality and the timings of the food. She's still eating 4 eating episodes a day, each one very low calorie, using poor quality nutrition. Research study here for you, looking at the effects of low glycemic index diets compared with conventionally healthy diets and polycystic ovary. Conclusions: to the best of our knowledge, this study provides the first objective evidence to justify the use of glycemic index diets in the management of PCOS. Wanting to keep carbohydrates down, in a similar PCOS study, a high protein, low carb diet has been found to be more effective than a low protein, high carbohydrate diet. Improving symptoms of depression and anxiety, reducing total cholesterol, raising HDL, and maintaining endocrine improvements during weight management. We have to get our clients moving. Ideally, I'd be looking at more like a HIIT-based training, high intensity interval training. Now, that might be a million miles away from where you can start with your client, but we have to start somewhere, don't we? We have to move towards somewhere. Exercise has been shown to raise sex hormone binding globulin, as well as lower inflammation. So now let's start to dig into some of the supplements that have research behind them. I'm only going to bring you what I can find reputable research, as well as my clinical experience of using. The cinnamon extract has been shown to reduce insulin resistance by potentially insulin action. 15 women in a small-scale trial with PCOS were randomized to daily oral cinnamon or placebo for 8 weeks. Comparisons of post-treatment to baseline insulin sensitivity indices using fasting and 2-hour oral glucose tolerance tests showed significant reduction in insulin resistance. Well, how easy is it to work with cinnamon? You know, at the very minimum, start to get people to do it from a food-based source. In a 2005 trial, 200 micrograms per day of chromium picolinate was found to improve glucose tolerance compared to placebo. In a similar trial, a dose of 1,000 micrograms per day given without change in the diet or activity levels caused a 38% mean improvement in glucose tolerance. And then looking at a small-scale trial on alpha-lipoic acid, 600 milligrams of alpha-lipoic acid was given twice daily for 16 weeks. At the end, there was a 13.5% improvement in insulin sensitivity. So I very much see chromium, cinnamon, and alpha-lipoic acid going hand in hand. And you'll see that I've used that in the case study that I bring you in just a minute. L-carnitine plays essential roles in energy production. We know how important it is for transporting fat into the energy transport chain for ATP production. However, a 2008 study saw that PCOS concentrations were significantly lower. PCOS women had significantly lower concentrations of carnitine than a healthy woman of the same age. There was a research study, and quite interesting, looking at using walnuts to support HDL and LDL ratios. So because of its high omega-3 intake, it was shown to decrease LDL by 6%, increase insulin response, increase adiponectin, decrease glycosylated hemoglobin, and increase sex hormone binding globulin. It's also shown to improve diastolic blood pressure. So omega-3s themselves, so a high omega-6 to omega-3 ratio is associated with higher circulating androgens, whereas plasma omega-3 status is associated with a less atherogenic lipid profile. So getting a good quality fish oil in there is really important. It also helps with decreasing liver fat or non-alcoholic, so NASH, reducing triglycerides and reducing blood pressure. Looking at optimal vitamin D levels in PCOS sufferers, 72% of subjects were found to be vitamin D deficient. Now, this study was in Scotland. So, parts of Scotland, I think they're probably 99% vitamin D deficient. But it was still a useful research study to bring to our attention the importance of vitamin D deficiency, which we know is a massive problem in the UK. And sufficiency that we're looking at is sort of 75 to 150 nanomoles per litre. Now, I often use a big dose of vitamin D 1 day a week for an 8-week period. And actually, research has shown that this is a much better method of correcting a vitamin D deficiency, maybe following up to the 8 weeks with just a low dose maintenance to ensure that we stay within that optimal level. We want to continue to balance hormones naturally by increasing dietary fiber, increasing lignans in the diet, ensuring adequate protein intake, which is important for sex hormone binding globulin. Proteins are needed for metabolism of estrogen in the liver, and they play a major role in a low glycemic load diet. Now, this is a really interesting research study on a comparison between pharmaceutical medication and NAC for induction of ovulation in PCOS clients. Conclusion: NAC is proved effective in inducing or augmenting ovulation in polycystic ovaries. These are great research studies to be able to show your clients, this is why I'm doing what I'm doing. We know we talked a lot about B6 last week, didn't we? And the importance of it with PMS. We know how important it is for hormonal synthesis, for reducing androgenic and estrogenic transcription responses. We also need it. We know its importance in remethylating homocysteine to methionine, and we talked about potential high homocysteine. Magnesium is important for insulin resistance and to help with the reduction of stress. We've talked about omega-3. We're looking at about 2 grams of EPA a day. Also, research study here on curcumin, which concludes the total effects of curcumin on metabolic factors in PCOS-induced rats were evaluated for the first time. Our results indicate that curcumin, with the ability in adjusting lipid profile and increasing the sensitivity to insulin due to the presence of flavonoids, may be considered as a natural effective compound to improve some metabolic syndrome in patients with diabetes and or polycystic ovaries. Another research study looking at plant-derived anti-androgens. And these are some of the androgens that we used, or the plant-based properties that we used in this research study. So this is all part of one study. And I've just pulled out some of the research. Reishi mushrooms have the strongest action in inhibiting testosterone. Licorice may also reduce testosterone levels, which can contribute to hirsutism in women. Green tea may have anti-androgenic effects because it contains the active ingredient EGCG, which inhibits 5-alpha reductase conversion of normal testosterone into DHT. Spearmint has been thought for many years to have testosterone reducing properties. Its anti-androgenic properties reduce the level of free testosterone in the blood. Myo-inositol treatment increases ovulation rates by a significant degree in women with oligomenorrhea and PCOS. Continued treatment also results in significant weight loss and leptin reduction. Myo-inositol administration is a simple and safe treatment that ameliorates the metabolic profile of patients with PCOS, reducing hirsutism and acne. These are awesome pieces of research, guys. This is showing what powerful tools we have in our kit bag. Go to the doctors, get given metformin. They've not got a lot else to give you. Yes, they've got some anti-androgenics. They come with side effects. Yes, they've got statins. Do you want to be putting a young 21-year-old on statins the rest of their life? Ideally not. Chaste, Vitex, Agnus Castus acts on the hypothalamus and pituitary glands by increasing luteinizing hormone production and mildly inhibiting the release of follicle-stimulating hormone. This would be effective for cases of PCOS which have a progesterone deficiency. Just looking at some of the dosages of effective chaste tree recommendations. So in polycystic ovary, clients were looking at 200 to 1,000 milligrams a day in cases of moderate prolactin excess. However, if we've got high levels, we're looking at 1 gram to 2 grams a day in divided doses. Also thinking about the benefits of indole carbinol and DIM to increase the protective estrogen metabolites to hydroxyestrone, increase glutathione to supporting detoxification, and increase glucuronidation. What about zinc? It's involved in over 200 different enzymes in the body. It's important for sexual development, has a synergism with growth hormones and insulin. It's also really important for the integrity of the skin. And then the saw palmetto. It's an extract that may non-competitively inhibit 5-alpha reductase, therefore preventing the conversion of testosterone to the more aggressive DHT. We know a lot of research have been using saw palmetto in benign prostatic hyperplasia. So we know the thought process of it in testosterone conversion or inhibiting testosterone conversion. Another research study here for you on green tea concludes green tea has thermogenic properties, promotes fat oxidation, beyond that explained by its caffeine contents. Green tea extract may play a role in the control of body composition via sympathetic activation of thermogenesis, fat oxidation, or indeed both. Additional therapies that may be considered: rhodiola as an adaptogenic blend, nettle root to help modulate testosterone, flax seeds for its estrogen balancing and detoxification benefits. A research study looking at berberine in comparison to metformin to support women with metabolic characteristics. Conclusion: intake of berberine improves some of the metabolic and hormonal derangements in a group of treated Chinese women with PCOS. Main effects to be related to the changes in body composition in obesity and dyslipidemia. Further controlled studies are needed for the assessment of the potential favorable metabolic effects of berberine in women with PCOS. It is, however, effective. So I'm now going to take you through one of my case studies. Now, the reason I picked this one, I'm always going to write a case study, kind of go through my thoughts, who have I worked with this condition and who would bring a really interesting case to other people. Now, this client is a really interesting, she's a 23-year-old originally from Lithuania. She moved to UK 2 years ago to study at the local university. She's got no formal diagnosis. However, there's a big lack of medical input. The purpose of the appointment was to discuss the absent periods and her weight management. Now, she put her weight management initially as quite high. The BMI is 21.4. She's far not overweight. Weight to hip ratio 0.82. She's on no medication. She lives here with a boyfriend, but they've got quite a volatile relationship. She admitted she's quite aggressive towards him. It wasn't helped by the tone of her accent. Her accent is quite aggressive in the way that she speaks, but she says she had come close to stabbing her boyfriend several times. Okay, this is where it gets interesting. At the age of 9, she showed signs of puberty, breast tissue development, and the growth of pubic hair. Her mum took her to the GP in Lithuania, who said she was likely to start her periods in the next 6 months. They didn't do any testing, they just based on this clinical signs and symptoms. At the age of 16, and there was no significant medical history, there was nothing she could tell me between 9 and 16. Her parents did get divorced, but she said actually that was not a negative in her life, it was almost a positive because her parents used to argue. That was the only thing. There'd been no surgeries, there'd been no pharmaceutical drugs, there'd been no nothing between them. At the age of 16, she'd had no menstrual cycle whatsoever. So mum took her to the doctors, where she was told she was a late developer, nothing to worry about. Okay, so we're either an early developer or a late developer. Well, she's had the label of both. At the age of 19, still no menstrual cycle. So she went back to the doctors, who put her on the OCP to induce a withdrawal bleed. Well, it did just that. she had a cycle, 21 days of taking the pill, withdrawal, bleed. Back on the pill, withdrawal, bleed. But this isn't a menstrual cycle, is it? It's an artificial withdrawal bleed. Now, from the age of 18, her relationship with food was challenging. She felt fat. She started faddy diet. She did lots of carb restriction, excessive exercise. But her BMI never dropped significantly. There was some binge behavior, but the only compensatory mechanism was exercise. So she would eat a packet of biscuits and then she'd go work out for 5 hours. The client reported she'd have to work hard to maintain a BMI. So I had no concerns about like an anorexia nervosa or not even a bulimia nervosa underpinning this. But her relationship with food was definitely not a healthy relationship. She stopped the OCP at the age of 20 and felt that this was masking symptoms. She does remove excess facial and abdominal hair. She's had no subsequent menses. So she's never had a period on her own. She moved to the UK. She's not seen the GP. She's not registered with the GP since she got here. Continued to have food restrictions. She used MyFitnessPal app like religiously. Calorie tracking, exercising at the gym. At university, she was stressed. She'd just finished her second year, and her third year was supposed to be a gap year, and she didn't have a placement organised. And this, she said, was a big stress for her. So her goals were to have a regular menstrual cycle, to support her fertility, nowhere near ready to have a baby yet, but she knows she won't get pregnant because she's not having a menstrual cycle, to lose weight. Now, I didn't really want to focus on weight loss because I felt it's quite an unhealthy relationship. We talked about sort of optimal body composition. We talked about optimal nutritional intake, feeding the systems within her body. So budget was really low because she's a student. She'd just got a part-time job working in a factory. So I sent her to the GP. I wanted to register with the university doctor to get her FSH, her LH, progesterone, testosterone, sex hormone binding globulin, and her vitamin D. She did agree that she would do the thyroid plus. She was really interested in the thyroid, particularly because she felt that that might be why she wasn't losing weight, and a comprehensive adrenal stress index. So we looked at foods that we were going to focus on to put in: green tea, nettle tea, spearmint tea. Low, they don't cost very much money, these things, even making sure that they were organic brands. Increase their cruciferous vegetables, licorice tea for its cortisol-sparing properties, golden milk before bed to induce good delta wave sleep and its anti-inflammatory properties. Increased smash. I don't mean the instant mashed potato. I'm talking about all of the oily fish. Handful of walnuts each day. I gave you the research why, and to embrace food as part of medicine. So I really wanted to work on her relationship with food in a positive manner. She focused on sleep hygiene. She was in bed on her phone. There was no relaxation. She said, we usually argue before bed, and then I lie in bed with my back to him on my phone. It's quite a volatile relationship, like I said. So I wanted to focus on one relaxing activity a day. Reduce HIIT training and include one rest day and one yoga class. Whilst I said I like HIIT training, she was doing too much of it in an obsessive compulsive manner. Supplemental, I used our blended chromium, cinnamon and alpha-lipoic acid 4 times a day. I used it 4 times a day because alpha-lipoic acid has quite a short half-life of only about 2 hours. So personally, I like to drip it in over the course of the day rather than using like a big amount. I used our powdered myo-inositol with vitamin B6, calcium and magnesium, 2 scoops a day. And I also used our multi-nutrient formula with saw palmetto, beta-cytosterol and zinc. Now, this on the pot, I'm sure by now you've realised I don't name products. I'm not allowed because of CPD restrictions to name the products. If you can't work out which product I'm referring to from the Nutri range, please do feel free to phone the Nutri team. This bottom product is aimed at men and the prostate. So I do always make sure if I use it for women, which I've used it very successfully multiple times, that I explain to them that I know that they don't have a prostate gland. I don't want them to think that I missed that lecture in my biology training. So she came back 4 weeks later. Her vitamin D was quite low at 38 nanomoles per litre. Her sex hormone binding globulin was just above optimal. So typically this is low. So this is what I'm saying. This client doesn't necessarily present atypical. She had a very high testosterone. It was a combined testosterone. Her sex hormone binding globulin was slightly above optimal, but her testosterone was more than double the optimal reference range. Progesterone was low, luteinizing hormone high, FSH within range. Referred by the GP for an ultrasound, polycystic ovaries. So this is her thyroid panel. So her TSH is normal even on a doctor's record. And this is why TSH is only looking at the tip of the iceberg. 1.17 is even within our naturopathic parameters. But look, total thyroxine low, free T4 low, free T3 low, and thyroid antibodies. So there's something autoimmune going on in there as well. Adrenals aren't as bad as I thought they were. Her morning cortisol is above optimal. I'd like it 5 to 6. She's 8. But her drop, what's more significant is the drop. So optimal would be 5.5 to 2.5. So half. Whereas she's gone from 8 to 2.81. So that shows a more significant drop in her cortisol levels. Think of it like you're on the ski jump out skiing. She's going for a much more aggressive downward hill. But she's got this mid-afternoon spike again. So she shoots up from 2.81 to 3.89. What does that tell us? That is most indicative of blood glucose imbalance. So her chromium, cinnamon, and alpha-lipoic acid were really an important intervention. And then she's got higher than normal cortisol before she goes to bed. Finally, I didn't get her DHEA-S tested because it wouldn't be available on the NHS and budget was a problem. But her salivary DHEA is low. Why is it low? Because her cortisol has been draining the bank account. So this doesn't mean her DHEA-S was low. This is looking at her salivary hormones. So what she reports, she stopped tracking her calories, although is somewhat anxious by this. She started a yoga class a week. Stress remains high because she's still not got a placement. She has been using the Headspace app and she's reflected on her high stress. So my second plan. I've continued with the chromium, cinnamon, alpha-lipoic acid. I've dropped it down to 2 a day because she has been on it 4 weeks. Continued with the myoinositol, continued with the saw palmetto blends. I've now put in a glandular concentrate for her thyroid. Starting with 1 a day in the morning, after 5 days increased to 2, after 5 days increased to 3. I don't like putting 3 in all together at the same time because it can give people symptoms of hyper. I then used an adaptogenic blend of ginseng, rhodiola, and cordyceps to help calm and rebalance the adrenals. And finally, added in some omega-3 fish oil. 4 weeks later, much happier, she secured a placement. She felt much more stable energy and was sleeping through the night, which is fantastic when we're thinking about the implications of melatonin and also things like serotonin, happy hormones, calming the adrenals. She's not been to the gym for a week, but had done 3 yoga classes and was loving it. Her food was a bit less manic. So she'd lost that obsessive control and was just a bit more calmer about it. And with that, I felt digestion would be calmer. So we've got autoimmunity, we've got to think about the gut. We've got research to show the support of berberine on blood sugar balance. So I made a decision to implement a bit of a 4R, not with a GI effect or anything like that, but I've used the berberine for a double-pronged approach for its antimicrobial properties, but also for its blood sugar sensitizing properties. Now, I've also felt that her liver was an area that I'd like to work on. So I used our high-strength alkalizing metabolic food, 2 scoops a day for 4 weeks, so 2 pots. Continued with the myoinositol, continued with the saw palmetto, continued with the thyroid complex, but she felt that 2 a day suited her better. 3 made her a little bit wired, so we dropped it to 2 a day. Follow up after 4 weeks, feeling cleaner and lighter. Energy was consistent, less erratic, less aggressive towards the boyfriend, generally enjoying life. Still no period. So I then went into doing some gut repair with the L-glutamine and NAG, and put in our 5-strain probiotic. Because remember, we've got this autoimmunity, thinking about gut first. Continued with the powdered and myo-inositol. Remember, the research says we can use it long term, and continued with the saw palmetto and the thyroid gland. I now use the multivitamin and mineral complex with herb to continue to support her adrenals and give her some thyroid converting factors. And I switched her from a fish oil to GLA and borage, just because there has been some research over using more of an omega-6 to help with hormonal regulation. So I thought I would add that in because she was using more fish, so the omega-3 was more secured in the diet. I didn't see her for 4 months because she was away doing her placement. She arrived in the office 4 months later to announce she's had a real period, her first ever period. She's now just turned 24. She's happy and feeling her body works. Her goals are now to focus on a regular menstrual cycle, to continue to support her thyroid, and to manage her emotions. How amazing is that? So plan 4, continued with the myo-inositol and the saw palmetto and the thyroid gland. Continued with some GLA, put the fish oil back in because she said, actually, I'm not really eating fish, and now switched her to more of a relaxant blend to support her adrenals with magnesium, taurine, and B vitamins in there. Remember, when you see a client such as this, it seems and feels as though it's such a complex position to, where do I begin? But remember, just start with baby steps. In that protocol, I worked on her gut, I worked on her liver, I worked on her androgens, I worked on her adrenals, I worked on her thyroid. But I also gave her an element of power, that she was back in control of her body, which actually doctors very rarely give people that empowerment. And to me, that makes such a difference to our clients. Now, remember, we do have resources available here at Nutri to support you on looking at which products might you choose to help with which symptoms. So obviously, I've given you some really broad spectrum, hopefully useful research. But this is like a great 1-page, 2-page picture for you to keep in your office, to be like a at the glance, what might be the best intervention for me. So that's it from me now, folks. I'm going to hand back to Sarah and take any questions, and hopefully I'll see you next week, where we'll be covering endometriosis and fibroids.
Thanks, Jo. That was fantastic. So, yes, I'll just go straight to some of the questions. We've got a couple of questions that have come in. So if we look at these. So what else might be causing insulin resistance? Nutritional therapist eating paleo, low carb, sugar diet, weight training, and taking all the right supplements.
Well, I would say in that instance, I'd like to look at the lab. So I'd like to look at HbA1c, I'd like to look at fasting glucose at a minimum, and I'd like to look at insulin. And then I think we need to look at more the androgen hormones. So hopefully what I'm trying to get across today is the complexity of polycystic ovaries. And whilst it's the most common endocrine female disorder that we will see, I would say it's actually probably the most complex, because it's so multifaceted. And if this is an individual that it makes it, I may have misinterpreted this, Sarah, so I apologise if I have. It makes it sound as though it's for the own practitioner, because that's the way I sounded, as though it's somebody referring to themselves. It may be somebody about one of their clients. Either way, I would say we absolutely have to start with lab work. So think about testing the gut, think about testing the adrenals, DHEA sulfate, which I do through TDL, the doctor's laboratories, maybe something like a Dutch test, because only when we see the whole of the bigger picture can we start seeing where it's going wrong. The other thing about taking all the right supplements, which is fantastic, is the client absorbing the supplements.
Yeah, absolutely. I think that was a great case study for showing that as well, that there's just so many different complex things that can affect. It's not just a case of going for the hormones and going for the insulin. No. So, I think that's, really, really great case study. Another question, what's the optimal fasting glucose level and what reading would indicate insulin resistance? And does the menstrual cycle affect the glucose levels? For example, is it higher in the luteal phase?
It often is higher in the luteal phase. Now, it's not just about the individual levels, it's about looking at them in the bigger picture. So it's about saying, I mean, you can, if I've got a client with insulin resistance, I can get them to do their blood glucose levels through the course of the day. You know, you can buy the kits, you know, the finger prick tests, you can buy them on, you can buy them on Amazon, you can buy them in Boots. And what I usually get a client to do is test 4 times a day for a week and record the data and send it to me. So when they wake up, before lunch, before dinner, and before bed. And it's looking for, so ideally, absolute creme de la creme of a fasting blood glucose would be looking at sort of 4 to 5 nanomoles per litre. That would be fantastic. I often see one of my insulin resistance clients wake up with a morning cortisol more like 7, 8 nanomoles per litre. I have got clients, type 2 diabetics, that are waking up with 9 and 10 when they first present to me. So you've got to look at it as part of the whole of the bigger picture. And then even if they've got a really obscure one, like say they've got 7, I'm like, what did you eat at night? Did you drink alcohol the night before? Because these are all the things that can influence. I'm sure yourself, I'm not insulin resistant, but if I drink wine at night, I pretty much guarantee you I'm going to wake up at 3 a.m. the next day. And I'm not talking excessive wine, I'm talking 2 glasses. I'm going to wake up at 2, 3, and I know my blood glucose levels have dropped. So you've got to keep asking those pictures around it. But that's what I'll often get people to do, is buy a blood glucose monitor, and then after that, maybe do like a day a week. They can continue to do 4 times a day, but the testing strips can be quite expensive. And of course, you can end up with bruises at the end of your fingertips where you've kept piercing them. So 4 times a day for a week, and then I'll often do a day a week thereafter, just so I can get a snapshot over how well we're managing these blood glucose levels.
That's great, thank you. So you mentioned water filters. What do you know? What brands are the best in the UK?
So I personally, I've done everything. I've been there, done it, worn the t-shirt. So I used to do water distilling, which I had the WaterWise machine, and optimizing, which I used a Pine Mag optimizer. Oh my God, that takes a long time because you're permanently like filling a boiling kettle. Personally, I've got an under-counter water filter now. I use the brand Water Filter Man, and if you Google Water Filter Man, it will come up to his website, and that's the whole house water filter system. I actually tested my house when I first moved in 18 months ago, and afterwards, after I'd done it, I did a doctor's data water test on it, and I was really happy that any toxins that were going through it, and fluoride is quite high in my hometown, had all been reduced significantly. Still picked up a tiny bit of fluoride, but it was minuscule in comparison to what it was.
Oh, that's great, thanks. Is there a way to differentiate androgens being produced from the ovary versus adrenals?
Not really in a lab test. And it's only when the researchers looked at ovarian, I want to say secretin, I mean the opposite. When they've used medication to reduce ovarian androgen production, have they then seen that androgens have continued to raise, and that's looking like it's coming from the adrenals. But I can't think, I'm not saying it definitely doesn't exist, but I can't think of any lab tests that would differentiate between the two of them.
No. And then this one's just, I think it's more of a comment, but coffee inhibits cortisol, question mark. I wasn't sure what that was.
That wasn't the inhibit pathway.
Yeah.
Sorry, was it a question or a statement?
I think it's it looks like a question, like coffee inhibits cortisol, question mark.
I think I know what it was, is in the inhibiting pathway. It's more linked to, there was a slide where it talked about inhibition and promoters of insulin, of course.
Yeah.
I think that's what the delegate is referring to. It's more about the link caffeine and the link over genetic SNPs that I was referring to in that case.
Okay. So what testing is recommended for PCOS clients who are what's this one? SX free through diet and lifestyle and have regular. Yeah. All right. Yes. Sorry. And through diet and lifestyle and have regular cycles, but want to start monitoring their ovulation for fertility purposes.
Well, the first thing that I would do there, and I'm going to talk about infertility in 2 weeks' time, and we're going to talk much more about cervical mucus and really exciting things like that in 2 weeks. So don't take all my limelight away from me today. But I would be looking at, so if they've got a regular cycle, and I've got a client with PCOS who has a regular cycle, but I referred to her, she's anovulatory. So you could ask the doctor to do a progesterone test at anything between. Now, if the client goes to the doctor and says they're actively trying for a baby, they can send them for a day 21 progesterone test. They can send them back on day 22 or 23 to pick up this progesterone surge. The problems are, it's a pain in the bum because you might keep having to go back for a blood draw, like day 21, 22, 23, 24. And if those days fall at a weekend, blood drawing might not be available. So one option is to test day 21 progesterone. Another option is luteinizing hormone sticks, which you can just buy online, and we're going to talk more about that in infertility, and cervical mucus checking. So, and temperature checking, of course. So they're sort of things that you could be doing at home quite easily. From a testing point of view, what I might recommend for this client, because she does have a cycle, is the rhythm test. And that's where you pick up levels of estrogen and progesterone over the course of the month. So you'll be able to pick up if there is a cyclical spike in progesterone. Is it around day 21? Does it drop? What does the picture look like? So that's the rhythm test from Genova. And I did mention that in the last lecture. You have to spit multiple times through the cycle, so like days 1, 2, 5, 8. And then at the end of the cycle, each one you freeze, you send the whole bag away. And what they do then is plot your estrogen progesterone levels over the course of the cycle.
That's great. Okay, so another question relating to, just 2 more questions now. How do you make sure you get enough food into 2 meals per day, especially when eating a healthy paleo type diet and also exercising?
Yeah, and it's a really challenging one. And please don't get me wrong, I'm not saying 2 meals a day is right for everybody. But if I've got a client that's already been doing calorie restriction, they've already been to a PT, we have to look at almost like resetting their insulin production. Like give the islet cells a bit of a break, which is where the having a long fast comes from. Now, actually, those meals need to be really nutrient dense with good quality protein, fats, and lots of phytonutrients. We can easily survive. And if you go back to sort of hunter-gatherer times, they certainly didn't eat 3, 4, 5, 6 times a day, which is what the more Western approach to meals are. Even if you think back to your childhood, like I wasn't brought up as a snacker, but it's been brought into everyday population by the fact that everywhere you go, food is so readily available. So actually, we don't need to snack. It isn't necessary. And you go back to hunter-gatherer times, and often they'd eat once a day because they used to go out and catch their food. So why are we at such high levels of endocrine disruption? Has to have something to do with dietary changes over the years. And actually, I think you can easily fit good quality piece of, let's say, an animal protein, get some good fats going in there, partner it with some avocado, let's say, and then half a plate of green leafy vegetables twice a day for a period of time. And I do this sometimes with people. I just say, look, let's do it for a month, and then let's go back to 3 meals a day. But actually, they're not going to starve to death as long as the meals that you put together for them are are good quality meals. Chris Kress has done so much research on intermittent fasting, reducing type 2 diabetes, reducing insulin resistance. Again, we never used to have epidemic levels of type 2 diabetes, did we? We didn't have children being diagnosed as insulin resistant. We do now. Why is that? It has to be the diet that we're eating that is driving these conditions.
That's great. Thanks very much. And the last one is it says amazing case, thank you, and just wondering why you didn't start with a liver support, possibly even a gentle detox to reduce androgen levels.
Now, I wanted to. I did think about doing that. I also had to go with what the client wanted, and this is quite a dominant client. So the liver support did come in. I used our metabolic food to be able to support the liver, and I used some NAC. But that did come a couple of steps down the line, partly because I just felt if I didn't control her adrenals, then actually I wasn't going to generally be able to calm her body down. I felt that her androgen excess was massively being exacerbated by her adrenals. I mean, she said she thought she was going to stab her boyfriend. So you have to look at the person that's in front of you. So I'm not saying liver support would often be my go-to it. She was just a really interesting case. I think she's one of only 2 clients I've worked with that's never had a period, not ever. Most of my PCOS clients have just got very scanty, maybe 2 periods a year. So I just felt that so much stress was going on, and this was driving, and also because she had such a poor relationship with food. When I went into doing the metabolic food, she used that as a meal replacement. And psychologically, I just wanted to initially build a good relationship with food before I was using the metabolic food as a meal replacement. So it just was, I can only say to you, you do need to go with your gut instinct about the client that's in front of you. And yes, sometimes I'll go straight for the liver. But in this case, I just felt her adrenals were a big factor. And then, of course, I got this wild ball over the thyroid autoimmunity, which actually wasn't quite what I was expecting. So then I was put a lot of emphasis on the gut being a driver of autoimmunity. So then the liver came in at the next level after that.
That's fantastic. So thanks very much for... I think just another question's come in now. If you are putting a client on 2 meals a day, would you tell them to have breakfast and lunch or breakfast and dinner? Which meal would you miss out?
Well, typically, if you're going to fast for 16 hours, I don't usually start with 16 hours because 16 hours usually I start with 14 hours. So that's from dinner to breakfast. In those instances, I would do a late breakfast and an early dinner.
Yeah. That's great. So thanks very much. I think that's been a really good overview of the PCOS, and we're really looking forward to next week the endometriosis and fibroids chat. So we'll make sure that we send out that protocol that Joe talked about with the notes and the link to the recording, so that'll come out to you. But any other questions that you've got, you can email to nutrition@nutri.co.uk, and we'll see you all next week. Thank you.
Thanks, Sarah.